So when you were just a microscopic embryo, your lower urinary tract and your reproductive system were actually built from the exact same cellular blueprint.
Yeah, the exact same one.
Right. And fast forward a few decades, and that invisible biological quirk is the reason why millions of women experience the sudden, just maddening spike in urinary urgency and recurrent UTIs during perimenopause and menopause.
It's honestly an incredible piece of biology that we rarely talk about. Those two systems remain functionally linked for your entire life,
Wow.
which means what happens to one invariably dictates what happens to the other.
Which is exactly the core of our deep dive today. Welcome in, everyone. We are unpacking the actual mechanics of why the bladder and the pelvic region seem to, well, suddenly change the rules during this specific phase of life.
Right.
And you've brought us a whole stack of clinical guidelines today, right? From the British Menopause Society, the BMS, and the American Urological Association, plus like clinical trial data and literature from pelvic health specialists.
Yeah, a lot of data today. And the intention here is to really look past those generic symptom lists you always see.
Oh, definitely.
We need to decode the underlying architecture of the body, you know, figure out how a shift in hormones triggers a literal ecological collapse in the pelvic microbiome.
A literal collapse.
Exactly. And then we'll look at what the clinical data actually recommends to break the cycle. Because, I mean, the standard approach of just throwing endless antibiotics at the problem, it's fundamentally flawed.
Yeah, let's start with that cellular blueprint you mentioned. The sources mention this embryonic structure called the urogenital sinus. And I found this fascinating because we tend to think of the bladder and the vagina as just, completely separate systems.
Right, totally distinct.
Yeah. They have different functions. They're treated by completely different medical specialists. You've got urologists over here, gynecologists over there. But biologically, they are born from the exact same tissue.
They share an origin point. So during fetal development, the lower urinary tract, which is the bladder and the urethra, and the lower reproductive tract, the vulva and the vagina, they both differentiate from that single urogenital sinus.
Uh-huh.
And because they come from the same embryological tissue, they remain densely populated with the exact same biological hardware throughout your life, specifically estrogen receptors.
So estrogen acts as like a structural master regulator for the entire pelvic region, not just the reproductive organs.
Yes. And that is the crucial missing link for so many patients. I mean, for decades, the medical community just referred to the changes in this region during menopause simply as vaginal atrophy.
Right.
But the sources show a major push toward a new term, genitourinary syndrome of menopause, or GSM.
Which honestly makes total sense considering vaginal atrophy just completely ignores the urinary side of the equation.
It does. The North American Menopause Society and the International Society for the Study of Women's Sexual Health, they propose GSM precisely because it captures the full spectrum of what's happening.
Right.
The data shows that up to 87% of postmenopausal women experience symptoms of GSM.
87%, that's massive.
It's huge. And it encompasses the vaginal dryness, yes, but it also includes the sudden urges to urinate, the painful urination, and the chronic infections.
So if the bladder and the reproductive tract are built from the same embryological concrete, essentially,
Just way to put it.
then a drop in estrogen isn't just an issue for the reproductive system. It's like the internal scaffolding of the entire pelvic floor is just rusting away. Both systems lose their structural integrity at the exact same time.
Exactly.
But what is estrogen physically doing to maintain that structure in the first place, like mechanically?
So estrogen is basically the fuel that keeps those specific tissues plump, elastic, and strong.
Okay.
When the estrogen supply declines, the architecture of the urinary system physically alters in a few distinct ways that lead directly to that intense sensation of urgency.
Oh, wow.
The most immediate shift is in overall tissue health. The vaginal tissues and the surrounding connective structures literally, physically thin out.
Yeah.
Because they are losing collagen and elastin.
Meaning the urethra, the tube that actually carries urine out of the body, it loses its physical support system.
Yes, and without that structural support from the surrounding vaginal tissue, you get this phenomenon called funneling.
Tunneling.
The urethra essentially begins to open prematurely just from the slightest bit of physical pressure.
Yeah.
Even if the bladder itself is mostly empty, a tiny, tiny amount of urine can slip into that upper part of the urethra.
Oh, and that triggers it.
Right, that immediately triggers a sensory signal to the brain that says, hey, we need to empty the bladder right now.
That perfectly explains the concept of stand-up urgency that was mentioned in the clinical literature. Like
Yes.
you are sitting down, you feel totally fine, but the second you stand up, gravity shifts, the pelvic pressure shifts, and that unsupported urethra just funnels open a fraction of a millimeter.
Just a fraction.
And suddenly it's a sheer emergency.
Exactly. Because the sensory nerves in the urethra are highly sensitive, so it doesn't take much fluid at all to trigger the alarm.
Wow.
And compounding that is the loss of strength in the urethral tissue itself. Estrogen maintains the cellular bulk of the urethral lining. It acts almost like weather stripping on a door.
Oh, I like that analogy.
Yeah, it keeps a tight, watertight seal.
So as the estrogen drops and the tissue thins, the weather stripping basically just wears away.
Right. The seal weakens, you get these micro leaks of urine into the urethra, and those sensitive nerves just fare off another false alarm to the brain.
Goodness.
And then, on top of all that, we have to consider the bladder wall. Estrogen plays a really major role in keeping the bladder wall flexible. Without it, the bladder becomes far more rigid.
So if it's rigid, it just can't stretch to accommodate fluid the way it used to.
Exactly. It reaches its maximum physical capacity much, much sooner. A rigid bladder sends a full signal to the brain at a much lower volume of urine. So it creates this state of chronic hypersensitivity for the patient.
Wait, I'm sure you, the listener, might be thinking, well, my hormones are fine, but I still have these exact symptoms.
Right.
Like, is this exclusively an estrogen problem? Because urgency and frequency definitely happen to people long before menopause, too.
Oh, absolutely. It is definitely not always hormonal, and the sources make a strong point to highlight non-hormonal drivers, too.
Okay, like what?
Extrinsic pressure is a major one. So if you have large uterine fibroids, they can physically press down on the bladder from the outside, which obviously reduces its capacity.
Makes sense.
Severe chronic constipation does the exact same thing. A full bowel places immense physical pressure on the bladder and urethra, leading to that same urgency.
So in those cases, it's just a simple lack of physical space in the pelvis.
Exactly. And then there are also nerve reflex mechanisms. The clinical data describes this psychological, neurological trigger, often called the key in the door mechanism.
Oh, I have absolutely heard of this. Yes. You're driving home, you feel completely fine, but the second you put your key in the front door lock, your brain just panics and you barely make it to the bathroom.
Yes, that is a perfect example. The brain and the bladder communicate via this super complex network of nerves. Sometimes a faulty reflex arc develops, where a specific action, like the key in the door, or a location, or even just the sound of running water.
Oh, running water gets everyone.
Right. It triggers the brain to aggressively signal the bladder to contract, completely overriding whatever the bladder's actual volume is.
Wow.
Pelvic floor physical therapy is actually highly effective at retraining those specific neural pathways. But for the perimenopausal and menopausal population we're focusing on today, the decline in estrogen really remains the primary driver.
Okay, but structural weakness doesn't fully explain the infections, right? Like a thinning bladder wall and a loss of urethral weather stripping, sure, that explains the urgency. But how does that physical thinning lead to a sudden, relentless influx of bacteria like E. coli?
So this is where we shift from a structural problem to a severe ecological problem.
Okay.
The thinning of the tissues directly initiates a collapse of the local microbiome. There's a very specific biological cascade that happens here. It all starts with estrogen stimulating the cells in the vaginal lining to produce a sugar.
A sugar.
Yeah, glycogen.
Right, and glycogen is basically the food source for the local bacteria.
Exactly. Specifically for the beneficial bacteria, the lactobacilli.
Mm-hmm.
The vagina should normally be heavily populated with lactobacilli. When these good bacteria consume the glycogen, they produce two really critical byproducts, lactic acid and hydrogen peroxide.
Okay.
And that keeps the environment highly acidic, usually maintaining a pH between 3.8 and 4.5.
Let's use a visual for this just to make it stick. Think of the healthy pelvic microbiome as like a lush, highly acidic pine forest.
Okay, I like it.
The estrogen is the rain falls, and it allows the pine needles to grow.
Yes, and the good bacteria thrive in that acidic soil from the pine needles. But when the estrogen drops, the rain stops.
The cells stop producing glycogen.
Right, meaning the pine needles stop falling, so the good bacteria essentially starve to death.
And without the lactic acid from those good bacteria, the soil pH neutralizes, the pine trees die off, and they leave the forest floor completely bare.
Which leaves the door wide open for invasive weeds to completely take over.
Right.
Pathogenic bacteria absolutely flourish in that neutralized pH E. coli, which the sources note is responsible for about 80% of uncomplicated UTIs.
Yeah.
And Gardnerella, which is associated with bacterial vaginosis, they just begin to multiply rapidly.
Because the good guys are gone.
Exactly. And because the vagina and the urethra are practically roommates sharing the exact same plumbing, those overgrown pathogens just easily migrate right next door into the urinary tract.
See, that biological cascade completely explains the statistics in the American Urological Association data.
Yeah.
They show that postmenopausal UTI recurrence rates jump to an alarming 55% compared to somewhere between 19 and 36% in younger demographics.
It's a huge jump. Furthermore, the clinical literature points out that these postmenopausal infections frequently become polymicrobial.
Meaning more than one bug.
Exactly. You aren't just dealing with a single strain of E. coli anymore. You have multiple types of opportunistic bacteria causing the infection simultaneously.
Oh, wow.
And that makes them exponentially harder to treat with just a standard narrow-spectrum antibiotic.
Which really forces us to look at the standard of care. I mean, if the root cause of these recurrent UTIs is a lack of glycogen starving the good bacteria and neutralizing the pH, then handing a patient a prescription for antibiotics every 2 months isn't actually addressing the problem at all.
Not even a little bit. I mean, antibiotics are necessary to clear an acute active infection. You need to put out the immediate fire.
Right, sure.
But using them as a preventative measure for recurrent UTIs in this specific population, it creates a vicious cycle.
Because it kills everything.
Exactly. Every round of antibiotics destroys whatever surviving lactobacilli are left in the microbiome.
Yeah.
You are essentially wiping out the last few defenders, ensuring that the environment is perfectly primed for the next infection as soon as the antibiotics leave the system.
So you're treating the symptom while actively worsening the root cause.
Exactly.
So what do the clinical guidelines actually instruct doctors to do to break this cycle?
Well, both the AUA and the British Menopause Society guidelines strongly recommend the use of vaginal estrogen.
Okay.
This is administered via creams, rings, or pessaries straight into the vagina.
Because it's treating the localized cellular environment, like
Yeah.
it tells the tissue to thicken back up, which produces the glycogen, which feeds the lactobacilli, which brings the pH back down to that hostile acidic level.
You nailed it. That's the exact mechanism. And the clinical trial data backing this up is incredibly robust. One of the studies in our stack showed a 51.9% reduction in UTI frequency in the year following a vaginal estrogen prescription.
Wait, really? 51.9? That cuts the infection rate in half just by restoring the local ecology.
Just by restoring the ecology, yeah.
Yeah.
And another clinical analysis evaluated the number needed to treat, or NNT, for topical estrogen cream and found it is just 3.
Okay, let's pause on that because if you aren't familiar with medical statistics, an NNT of 3 means a doctor only has to treat 3 patients with this therapy for one of them to experience a complete prevention of a recurrent UTI.
Right.
In the context of clinical medicine, finding a treatment with an NNT of 3 is remarkably effective. I mean, most preventative medications require treating dozens or even hundreds of patients just to prevent a single event.
It's practically unheard of for a preventative measure to be that effective.
And here is the elephant in the room.
Here we go.
The distinction between systemic absorption and local absorption seems to be the crucial piece of the puzzle that just gets totally lost in the public panic over HRT.
Oh, absolutely.
People hear the word estrogen, and they immediately worry about breast cancer, blood clots, or strokes. So what did the BMS guidelines actually say about the safety of vaginal estrogen?
It is so vital to separate systemic hormone replacement therapy, which circulates through your entire bloodstream to treat things like hot flashes and bone density, from localized vaginal estrogen.
Right. Very different.
Vaginal estrogen provides a microdose directly to the pelvic tissues. The systemic absorption into the rest of the body is so minimal that it barely registers above normal postmenopausal levels.
So it isn't flooding the body, it's just watering that specific pine forest we talked about.
Exactly, just the forest. The British Menopause Society states very clearly that vaginal estrogen is not associated with an increased risk of breast cancer.
Wow, okay.
It does not increase your risk of venous thrombosis or stroke above your baseline risk. In fact, the guidelines note that off-label use of vaginal estrogen can even be considered for women with a history of estrogen receptor-positive breast cancer.
Really? Even survivors?
Yes, provided they coordinate carefully with their oncologist, particularly if non-hormonal treatments have totally failed them. The safety profile of localized estrogen is just fundamentally different from systemic HRT.
Okay, that's hugely important to highlight. Now, the sources do also outline several non-antibiotic preventatives that can be used alongside, or even instead of localized estrogen. Things like methenamine hippurate. Did I say that right?
Yeah, methenamine and pipistrellus, it's a urinary antiseptic.
Okay.
So instead of functioning as a traditional antibiotic that indiscriminately kills bacteria throughout the entire body, it concentrates specifically in the urine and prevents bacteria from proliferating in the bladder.
Oh, that's smart.
It's an excellent alternative to daily prophylactic antibiotics.
The clinical literature also highlights D-mannose and cranberry extracts, but how do those actually work on a mechanical level? Are they just old wives' tales?
Not at all. There's real mechanics behind them. D-mannose is a type of sugar, and E. coli bacteria have these tiny hair-like projections called fimbria that they use to basically stick to the walls of the bladder.
Oh, gross. But okay.
Right. But D-mannose essentially acts as a decoy.
A decoy.
Yeah, the E. coli bind to the D-mannose floating in the urine instead of binding to your actual bladder wall. And then they're simply flushed out when you urinate.
Oh, wow. That is fascinating.
Yeah. And cranberry extracts containing specific compounds called proanthocyanidins work through a very similar anti-adhesion mechanism.
Okay, so it stops them from sticking. And what about replacing the bacteria directly? The sources emphasize specific targeted probiotics to recolonize the microbiome. But I assume we aren't talking about like a generic gut probiotic you grab from the grocery store.
Oh, definitely not. The strains matter immensely. You need bacteria that naturally colonize the vaginal tract.
Right.
The literature points to Lactobacillus rhamnosus GR1 and Lactobacillus reuteri RC14. Those are the strains with the most robust clinical evidence for this specific application.
Got it.
Yeah, taking a random digestive probiotic won't do much of anything for your pelvic ecology.
We also need to touch on the mechanical side of prevention, specifically pelvic floor physical therapy.
Yes, absolutely.
Because if the bladder isn't emptying completely, that residual urine just sits there.
Exactly. Stagnant urine is a perfect breeding ground for bacteria. Pelvic floor weakness, or conversely, a pelvic floor that is way too tight and cannot properly relax prevents complete voiding.
Ah, okay.
So physical therapy addresses the muscle mechanics to ensure the bladder is fully emptying, basically removing that stagnant pool where E. coli loves to multiply.
Wow. You know, when you lay all of this out, the whole picture becomes so much clearer.
It really does.
The journey starts with that shared embryological tissue. Because the bladder and the reproductive tract are built from the exact same estrogen-dependent cells, a drop in hormones compromises the structural integrity of the urethra and, at the exact same time, starves the protective bacteria guarding the bladder.
It is a simultaneous structural and ecological breakdown.
Right. And if you are dealing with sudden urgency, leaking, or cyclical UTIs during this stage of life, you really need to understand that this is a documented physiological condition. It is driven by cellular changes, it is not just getting older, and there are highly targeted, localized, and safe treatments that directly repair the root cause.
Exactly. The clinical community understands the mechanisms of genitourinary syndrome of menopause incredibly well, yet there remains a massive, massive disconnect in patient care.
It's so frustrating.
It is. And the sources explicitly note that GSM is chronic and progressive.
Meaning it gets worse.
Right. Unlike hot flashes, which may eventually subside as the body acclimates to a lower hormone baseline, the structural thinning and microbial collapse in the pelvis will only continue to worsen without intervention.
Left untreated, that foundation just keeps rusting away.
Exactly. Which leaves us with a pretty profound biological paradox to think about. Yeah, evolutionary biology suggests humans developed menopause.
Yeah.
It's called the grandmother hypothesis, so that older females could invest energy into the survival of their grandchildren rather than continuing to reproduce themselves.
Right, sure.
Evolution intentionally designed you to live for decades past your reproductive years.
Yes.
Yet the human body somehow failed to separate the survival of the urinary tract from the reproductive hormone supply.
Oh, wow.
We are evolutionarily designed to outlive our own pelvic infrastructure.
That is wild to think about.
And until medicine widely normalizes restoring that localized ecology, millions of women are just left paying the biological price for that evolutionary oversight.
Well, on that note, we are going to wrap up this deep dive. Thank you so much for joining us, and we hope this gave you the tools and the language to advocate for your own health. We'll catch you next time.